right. I am thrilled now to move on to our keynote. I want to tell you a little bit about our speaker and why I chose him. I really wanted a presenter who could relate to all of what each of us goes through each day. I don't think the world quite understands how complex our jobs are. Who better to hear from but one of our own? Dr. Cedric Jamie Rutland is a jack of all trades and a delightful human being. Jamie's a practicing physician in the field of pulmonary and critical care medicine and so much more. He practices pulmonary critical care in every setting, and he collaborates with industry in a number of cutting-edge areas that are advancing, particularly immunology and interstitial lung disease. The best thing about Jamie is that he has a very realistic but optimistic look on the world and on the career of being a pulmonary critical care physician. He doesn't let the day-to-day challenges stop him, and if one door closes, 3 more open for Jamie. He believes in self-accountability. Jamie is an outstanding communicator, as you will see, and I want you to know that if you see him around the meeting, please make sure to congratulate him because he's also one of our new FCCPs today. Please help me welcome Dr. Cedric Jamie Rutland.
Thank you so much. This is very humbling. Thank you for that kind introduction. I really appreciate it. But I think we're here to spread some messages, so let's get to it. I've been asked to talk to you guys about a new perspective on diversifying medicine. But when you actually think about it, like diversity, what does that even mean? For most folks, diversity ideally means people of different races, different genders, different ethnic groups, different religions, all working together cooperatively. But for me, diversity in medicine is so much more than that. It's beyond the bedside. It's beyond the clinic. It's beyond those white hospital walls that we're always walking down. In our world today, patients demand explanations. And if we don't give them one, misinformation fills the void. Diversifying medicine is finding new, creative ways to take years of our education and experience and communicate this knowledge to the public, all of the public, because the more we all know, the better we all do. We all know natural selection gets the best of those that choose not to evolve. You can't feast on the fresh leaves at the top when your neck is too short. The evolution of media, social and other, the newfound dynamic of post-COVID independence has provided so much opportunity in giving people more control to create a better life balance in terms of patient care. For me, this balance is 40% outpatient clinic responsibilities. With this, I still do what I love. I get to see patients, hear their stories, treat their diseases. But I also have the opportunity to learn the business model, to understand the ins and outs of insurance, to educate myself about the finances of medicine, an essential skill we as physicians do not receive in our training. In my clinic, I also work closely with PA and medical students. I always wanted to stay in academics, and I'm very jealous of so many of you out here. I even flirted with getting back into a university, but then I realized my calling is right here, right where I am. A lot of people have their thoughts, but I had a purpose before anyone else had an opinion. And as a private practice physician, I had to figure out a way to stay in touch academically. I also feel like physicians are losing power in healthcare. And I didn't feel like academic medicine did much to regain the autonomy we once had. 10% of my time is spent in the ICU, working with, not for, because there is a difference, another private practice group. I sign on for the hours that I want, and I work at night, 6 to 7 nights a month. And I get to do all the things I love about the ICU without burning out, without missing every holiday with my family. I finally own my own time. And for the other 50% of my time, I've been able to truly nurture my passion for education, whether it be for the general public or for my peers.
I want to thank all of my guests today. A special thanks to Dr. Cedric Jamie Rutland.
This is Barbershop medicine.
To be able to generate or manufacture a vaccine, you have to know what the virus looks like.
We really appreciate you being on today's special episode of Barbershop Medicine.
Jamie, Italo, it's great to be with you guys. Thanks for having me.
We're going to jump on the expert line and head out to the Los Angeles area where we're going to connect with Dr. Jamie Rutland.
You are a board-certified pulmonologist?
Dr. Cedric Rutland with the American Lung Association.
It's so much easier to prevent a disease than it is to treat it. Trust me. The doctor's in.
Yeah, one of the primary reasons we, minorities, are not getting the vaccine is because it's not offered in the places that we trust.
What we're working on as far as limiting and eliminating access to flavored tobacco
It's better now that you're thinking on now because you have to push it forward now.
And the actionable item for everybody that's listening right now is to learn CPR.
Sean White, Chief Medical Officer at Redefining, and I'm delighted to be joined by Dr. Cedric Jamie Rutland.
Thanks for having me today. Much appreciated. When you were going through your initial phase, what were those conversations like? I'm Cedric Jamie Rutland, and this is a day in my life. I do it all. I do it all day long, minute by minute, hour by hour.
Ease is a greater threat to progress. Hardship, meaning it ain't supposed to be easy. So we just finished that procedure. We got 4 more to go. I like people. I like talking to people, where they came from. I just want to know what brought them to that very moment where we are standing right now.
It hasn't been easy. This hasn't always been easy for me. You know, and I always go back to this story. Second year of medical school was really challenging. It was really hard. If there's one thing I have because of my mom who's sitting in the audience, it's awareness. And I began to notice that as I spent more and more time in the books and more time studying, I actually couldn't read longer than 35 minutes. I'd get up at the coffee shop, talk to the people next to me, horse around, meet new people, meet the owner of the coffee shop. I'm not really a complainer, but I did approach our school counselor and she suggested I see a psychologist. So I go to the psychology office at University of Iowa, where I went to med school, and I end up in a waiting room with 10 7-year-olds and a 26-year-old, right? Me, right? After some testing, it turns out I had ADHD, ADD, I didn't even know they were different at the time, dyslexia, and dysnomia. But apparently the amount of information I could absorb in those 35 minutes was insane, and that's how I got to where I was. I never looked at these diagnoses as a disadvantage, because I can wear many hats and pay attention to a lot of things at once. But when you need to focus on just one thing, being easily distracted, not great. So I started taking medication, methylphenidate, right, as needed. And for me, it was career trajectory changing, life changing. I took advantage. I started over in the middle of medical school. I learned my current curriculum, but went back and reread everything from first year to build on my foundation that was just full of defects. I filled these gaps. I stopped collecting dots. I began connecting dots. Immunology became my love. All the cytokines and chemokines released made sense to me. White blood cell recruitment, or just cell recruitment in general, it made sense. It was like the body making a bunch of phone calls and giving instructions, which led to patient symptoms. So I applied this, and I kept applying this moving forward, and I just built. I just laid this foundation of information, framed the doors, laid brick by brick. I learned to explain cell communication better than most and continued to expand my interest in pathologies. Started with interstitial lung disease and idiopathic pulmonary fibrosis. It's now transitioned to the immunology of asthma, pulmonary hypertension, interstitial lung disease, and bronchiectasis. These are all things that I like to educate about on my YouTube channel, Medicine Deconstructed.
Just think about a cut on your hand. The two areas of the cut are going to be able to touch one another, and then the healing cells go in between that cut and mend that fence. In the alveoli, which is an empty space
when you have that break, if you don't catch that other side to try to heal it together, you're just gonna keep laying down that scar. Let's go inside the body, take a dive in, and look at what asthma actually is. What's up, Paulin? How you doing? So it looks like we're in the airway. Let's talk about what surrounds us. Once this allergen or this antigen hits this airway epithelial cell, the airway epithelial cell is going to secrete certain cytokines, what we call alarmins. There's a concept called antigenic drift. And what happens is the hemagglutinin protein, that structure that you saw on the virus, changes a little bit every single year. So as these amino acids change, so does the virus. But remember, there are 5 antibodies floating around your bloodstream: IgA, IgM, IgG, IgD, and IgE. When you look at the structure of an antibody, there are heavy chains and there are light chains. Antibody tips can change the way they look to bind specific targets on organisms when we're sick. This tip is called the Fab fragment, and these fragments have been manipulated by scientists and have led to monoclonal antibodies. Those are going to bind to specific products. But new particles, which are pieces of the antibody called the nanobody, have been created. A nanobody is a fragment of the heavy chain. It's basically just the tip of that heavy chain. And what's being done is linking this tip with other tips which may bind other products simultaneously. Imagine having to only take one medication that binds multiple targets instead of taking 10 different. And so, when you think about it, when we're talking to patients or we're talking to our colleagues, there's different language that needs to be used. But all of this came from my diagnosis, and my ability to communicate came from sort of neurodiversity. It's all thought of as a disadvantage or a disability, but it wasn't really. I understood the need for diverse forms of communication due to my own struggles. Concise, visual, entertaining delivery of information was necessary, and it's how I educate. This is how I effectively communicate with all patients, all my patients. Yes, those who think and look like me, but also those who are culturally, ethnically, educationally, spiritually, all the ways you can think of, different from me. Black Americans are over 3 times more likely to die of particulate matter exposure than white people. Exposure to dangerous pollutant harms health by increasing the risk of asthma, heart attacks, strokes, cancer, and low birth weight. When inhaled, soot particles get into the lungs and kill up to 200,000 people annually. This risk can be attributed to environmental injustices stemming from the historical legacy of redlining, structural racism, and unfair zoning practices, allowing polluters to build power plants and toxic industries near and in black communities. In short, diesel trucks are driving through black neighborhoods. They ain't driving through white neighborhoods. And I know my culture, but I have to continue to learn others' cultures as well, because I don't know everything. But I do listen really, really well. But then I got to this point where I wanted to know what drove me. What paved my path? What motivated me to see people, to hear people for who they are individually? And I know my wife might be saying, he doesn't hear me sometimes, but I do. But what I'm gonna show you next is not only how I arrived at my purpose in medicine, but also how I continue to move forward. And what follows right now, and I have 2 beautiful little girls, right, an 8-year-old and an 11-year-old, but what I'm about to show you is my older daughter explaining something to me. She's gonna communicate something to me that she got from her teacher, and you're gonna see this right now.
My dad's black, and then she said, well, then your dad might know about the slave because his ancestors a long time ago. Like, tell her!
Thank you for sharing that.
Thank you. I film a lot at home, and so the kids come in after school and they just kind of say whatever's on their mind. But if you didn't get that last clip, my daughter's teacher told her to ask me about slavery because I was black, and I would know about it. She's a teacher in America, and I'm supposed to be the expert. I didn't know how to respond. So I learned, right? It turns out that my family is lucky enough to know a little bit about our history as it was written down. We have family members and slave masters that wrote letters. And someone in my family would know, and I've got some of these letters to prove it. Here's one of them.
I give and bequeath with my wife, Keziah Westmoreland, all my Negroes, Dina and Rachel, Elsie and John and Mary, Isaac and Mark, and all their increase, if there should be any. Reuben Westmoreland, Coweta County, state of Georgia, first day of September, 1845.
That was my great-great-grandfather's slave master reciting the names of his Negroes in the document. The names mentioned are also within my family, but the names are Dina, Rachel, Elsie, my aunt's name, John, my brother's name, Mary, Isaac, my great-great-grandfather, and Mark. So yeah, my daughter's teacher was correct. I guess I do know something about slavery because of my ancestors. But that's what a stereotype is. It's an assumption that it's not always wrong, but it cuts off your ability to look deeper, to see someone as themselves, independent from all stereotypes and preconceived notions, to see a person's whole unique story. If a written word is the same, that's plagiarism. And in DNA, it's cloning. But not a single one of us is the same. This is my great-great-grandfather, Isaac Westmoreland. He was born a slave, along with his mother, Elsie, like I said, my aunt's name, sister Mary, and brother Mark. But slavery wasn't the most defining or interesting part of this man's life. In his letters, he barely mentions it. He had a shoemaking business. Look at my shoes. You guys all know that I'm a sneakerhead. But with that business, he managed to send 9, and I'm gonna tell you this again, 9 of his 11 children who survived adulthood to college. To college.
Dear brother, I married a wife and raised 10 as fine children as has ever been raised. Hattie died about a year ago, leaving 9. You may feel proud of your nieces. Eva and Mamie have both married. Charles teaches school in Kansas City. Will carries mail here in Atlanta. Julius is in Boston. He's in bookkeeping. Son is Ike. He is in the city of Washington. Edgar, my baby boy, he works at the summer resort above Boston. When they close, he gone in school. Take care of yourself, my dear brother, and try to meet me in heaven. I remain your loving brother till death, Isaac Westmoreland.
It's crazy that we have these letters. But he was so proud of his kids and all that they had accomplished. His goal was to do something for his family. Knowing all the disadvantages that they faced, I know for sure he didn't think about what was fair or not. He didn't think about why it was impossible or what he couldn't do. He just put one foot in front of the other. No excuses, no complaints. But this is a heavy weight on a person. Having to defy what is expected of you, wanting your children to escape the world that sees you only as one thing. All of what my great-great-grandfather went through. No complaints. He just kept moving. I imagine him as a patient. What would he be thinking? In the world he came from, would he even bother seeing a doctor? Did his pain ever matter? Would he even feel comfortable communicating his symptoms if he had them? Remember that first definition of diversity, the part about different races, religions, etc., all working together. To achieve that, we, all of us, me included, must remain vigilant and park our biases outside the examination room. Not just because it's rude and insensitive or ignorant sounding, but because medical stereotypes have real clinical outcomes that can be deadly. In the United States, rates of stomach cancer in men are highest for Koreans, and rates of cervical cancer are highest among Vietnamese American women. If you group all Asian people together in a single stereotype, you're gonna miss that difference. Half of trans people report being mistreated medically. A quarter of those don't even seek health care because of this fear. And stereotypes also persist in my community. There are still ideas that persist about physiologic differences between Black and white patients. Beliefs that Black women don't feel pain come from slavery. Surgical experimentation on Black women without anesthesia kind of proved that years ago. Could this explain the higher maternal mortality rates amongst our population? The spirometer is given a racial correction because of the perception that African Americans or blacks had inferior lungs. The big fact is we didn't, we don't. We were just doing all the work that led to inflammation in our lungs. But this was all based off something Thomas Jefferson wrote in 1785. It's 2023. This all has consequences. You guys all know this. As a doctor, to do my job effectively, I have to break through these stereotypes of who my patients are and those false notions of who I am. Third year of medical school, I was on an OB-GYN rotation. I was on Gyn-Onc for 10 days. At University of Iowa, you do Gyn-Onc for 10 days. I mean, you did, God, 15 years ago. There was a 77-year-old female with metastatic ovarian cancer in the surgical intensive care unit. This was actually my first ICU experience too. I was the med student on the case, and we all remember this. We have all the time in the world, right? We have all this time. So I updated the family daily, drew pictures, showed x-rays, explained CAT scans. This is when I really taught myself how to read imaging. This family was from the northwest corner of Iowa, and they were farmers. Typical all-American farming family. Yeah, they were white. They didn't look like me. And when I first began to update them, when I walked in that room for the first time, you could feel the tension in the room. They weren't comfortable with me. As a black person, you know when it's that. But I kept going. I explained it all. It helped me. It helped them. We got more and more comfortable. I was being me, and they were open to letting me explain because they didn't have a choice. I had the most time by far. My 10 days on the rotation went by quickly. But I remember the P family fondly. I left the rotation. The very next day, my classmate Kevin, who is a rad-onc in the DMV area somewhere, he finds me in the hallway. He's like, Cedric, remember the P family? I was like, yeah, I do. Kevin and I weren't friends. He's like, well, Mr. P said something I thought was racist. What'd he say, Kevin? He said, I've never loved a colored fella as much as I love Jamie, but I do. I almost let it bother me, but the guy said Jamie. Then I turned to Kevin and I said, it wasn't racist. It was quite the opposite. At that moment, I realized me communicating openly with that family may have changed Mr. P's outlook and that family's opinion of an entire race of people. All I did was use my gift, communication. I felt good at something besides basketball. We may not always have 10 days to connect to a patient or their family that doesn't like them because of their own prejudices, but it's still on us to try. The lesson for me was this. Kevin was stereotyping because of the language he used to communicate his thought and appreciation for the care they received, the language the patient's husband had used. It had clinical significance. Instead of hearing the family is happy with the care their relative received, Kevin heard racist old white man from Iowa and not the clinical context of his statement. This happens. I want you guys to take a look at this picture. Can you tell which one is my grandfather? Yeah, look closely. So my grandfather started his career during World War II with the Tuskegee Airmen. That's when the United States trained black fighter pilots for the first time. Everybody knows this. Granddad wasn't a pilot. He was a civilian who worked in logistics. He was always where the action was. My mom and her siblings grew up in Europe. My mom speaks French and German and English, and I just speak English. We'll talk about that later. But Granddad stayed with the US Air Force after the war, eventually retiring as a top civilian at McClellan Air Force Base in Sacramento. Even though Sacramento isn't the Deep South, racial discrimination, particularly in housing, was rife in those post-war years. Granddad was unable to do what his white coworkers did easily, routinely, buy a house in a decent neighborhood. But he got around the problem. He asked his white friend to buy a lot in an all-new white subdivision, then sell the lot to him. I think about my granddad having to fight a stereotype that hard, fighting your way to get the basic equality you deserve, having to jump through hoops to get your basic needs met. He was the man who raised me as a son. I'm going to tell you something that you're probably going to find interesting. He always told me, it's never because you're black, boy. That's what he would say. He didn't want any of us, including my brother and siblings and everybody else in the family, he didn't want us thinking that there were limits. And I never heard him once complain, despite the era that he lived in. He picked me up every day after school. Mom was at work during the day and law school at night. And in the 5th grade, Sister Ann, I went to Catholic school, she made us write down 2 short-term goals and 2 long-term goals. Short-term, score 20 points, get straight A's. Long-term, get a scholarship to North Carolina or Georgetown, and then go to the NBA, or go to medical school and become a doctor. I put those goals on my grandparents' refrigerator. They remained there for 20 years. My first year of college, Granddad would take me from Sacramento to UC Davis every other weekend. I was recruited to play hoop. But on one of those drives across that YOLO causeway, Granddad had a serious look on his face. He's driving, and Granddad always drove a Jaguar, but he turned to me to say, listen, boy. He didn't say boy, but I can't say the word he used. You can't chase women, play basketball, and try to go to medical school. One of those has got to go. I quit basketball. I wasn't sad, I wasn't mad. My knee hurt at the time. It probably made it easier. But he was always direct with his communication towards me. It was very effective. We all know that communication means the imparting of exchanging of information or news. And when I applied to medical school and interviewed at the University of Iowa, there was no way I wouldn't be there. I loved Iowa. I still love Iowa to this day. But I also knew I didn't have the academic record of the average student accepted, or so they published, right? You get there, you're like, did you really have a 3.9? Oh, bro, I had like a 3.3. Anyway, several months after my interview, I received a letter, and it was that small envelope. And we all know what the small envelope means. But it read, we will place you on the out-of-state wait list, number 104. I was like, shit, number 104? I had been accepted at Howard, and I figured I was headed to DC. Not a bad way to go, but I wanted to go to Iowa. So in the letter, I was labeled as a number. And at that point, I decided I wanted Iowa to know my name. So I did what most applicants don't do. I called every day. Annette answered the phone most of the time, but occasionally Penny would answer, Linda would answer, and others would answer. My legal name is Cedric, but I preferred Jamie. My middle name was James, and my grandmother decreed that I would be called Jamie. But from Iowa, they would say, hey, Cedric, how's it going? How's the weather in California? I got to know them very well since I called every day. But my final sentence was always any movement on the wait list. So you get 3 weeks of this, right? And I'm calling every day. And I went from like 104 to 97 to 75 to 69. I can tell you every single number, but I've got to keep this shorter. But I got all the way to number 7. And at this point, I thought I had a shot. Then a couple days later, I saw this phone number that started with area code 319 on my phone, Iowa City's area code. And it was Linda. I knew their voices now. And she said, Jamie, not Cedric. And I said, I'm in? She said, yep, you're accepted. I heard the entire office in the background clapping. But I went from number 104 to accepted because I communicated. They knew my name because I communicated. For one of the first times academically since college started, I wasn't a number. I had communicated and I formed a connection that other numbers most likely had not. The great thing about that year before medical school is I got to spend the last year of my grandfather's life with him. Of course, I didn't know it at the time, but my grandfather was a heavy smoker. As a young man, he was. And in the early 80s, he rolled around with an oxygen tank. You can see the nasal cannula here. And he never left the house without his inhaler zip bag. My goal was to understand what all of those inhalers did, which is probably why I'm a pulmonologist. But Granddad couldn't make the white coat ceremony, but he saw the pictures. And in late October of 2005, which was first year of medical school for me, he was admitted to the hospital with a small bowel obstruction. He had surgery, made it through the surgery, but due to his significant emphysema, he was tough to wean from the vent. I didn't know what any of that crap meant back then. But I didn't know anything or nearly enough to communicate with my family. I knew nothing. I didn't know what to say. In late November 2005, my family had elected to palliatively extubate. I obviously understand those terms now. And on 11/27/05, my grandfather, my dad, died. I find comfort knowing that he wrote me the last thing he ever wrote anyone. And he just wrote, like, his words were, just remember to call me and be nice, right? And he wrote those words down. But I wasn't there, and I never went home to see him. I never went home to say goodbye. My mom, my uncles, my aunts encouraged me not to go because I was in med school and studying, and I thought you went home for other people. I thought you went home to be with your family. I didn't realize that you go home for you. I didn't realize that you go home to say goodbye and let go. And I try to communicate this to lots of people during end of life in the ICU. People don't realize how special that moment is to be able to be next to your loved one at that time. I went to his grave for the first time a couple years ago with my wife and 2 daughters, and I cried. I needed to, right? But because I didn't go home, I'm constantly chasing a bedside I'm never gonna catch. And this event was the single source of my motivation to practice medicine and rush to the bedsides in the ICU, rush to the bedsides on the floor. I always want to communicate with these family members. I want to explain everything because I want family to understand, because I didn't. Communicating with family members is just as difficult, perhaps more, as learning how cells and the body communicates. But just as communicating with family is extremely important, to be a successful healthcare provider, understanding cellular communication is essential in diseases we see: COPD, interstitial lung disease, idiopathic pulmonary fibrosis, EGPA, sepsis, heart failure. Mastering this knowledge and coupling it with superior communication skills is crucial. I think of pulmonary critical care physicians as the alarmins of healthcare. We are the damage-associated molecular patterns. We are the cytokines. We must learn cellular communication and how it pertains to disease. And more importantly, we must also become comfortable teaching these lessons to family, friends, and patients, because our communication directly impacts how families receive bad news, good news, interpret it, and disseminate it to other family members and friends. And those collective interactions, our ability to communicate, dictates how society views healthcare. And that impacts further patient interactions. And that falls on us. I know we wear a lot of hats, but when shit hits the fan, it's us doing the caring. Look at the pandemic. Who needed to communicate? We did. Pulmonologists and critical care doctors. It's a heavy responsibility, but it's what we signed up for. My remarkable grandparents had 4 kids. My mom is the baby sitting on the lap of her mom. It's my uncle, my aunt, my other aunt. Their children became a social worker, a lobbyist, a lawyer. My mom, she's here in the audience. You can stand up if you want, Mom. And her twin sister, who's a journalist. She's being too shy to stand, but she's not really a shy person. At age 50, my grandmother went completely blind secondary to retinitis pigmentosa, something that's easily treatable now. But she never saw me. That was when her writing career took off. She wrote more than 30 published books, most of them Harlequin romance. You should see the things that she wrote. I was like, Grandma. Anyway. Damn. Anyway. Her first book was a memoir. It was called The Trouble with Being a Mama, now titled When We Were Colored, A Mother's Story. I didn't really like the title change, but whatever. But it's about how it doesn't matter if you're black or white, mothers are mothers. You guys can Google Eva Rutland, you can read the books, and Grandma was pretty cool. In the 40s, she had a very large thyroid goiter. She went to Atlanta, where she knew all the black doctors, but none were trained to do the surgery she needed. So a white doctor was brought into an inadequate black hospital to an unfamiliar operating room without his usual nursing staff. He made a mistake. He severed a recurrent laryngeal nerve. You guys all know what that means, right? Vocal cords are paralyzed. For years, my grandmother struggled to breathe. But during the birth of my mom and her twin, Grandma obviously needed to take those big, deep breaths to push. The doctor at the time put a tracheostomy in. She was 26. After the birth of her twins, Grandma looked up at the doctor and said, "Leave it. I can breathe." She breathed through this, one of these tiny old-fashioned metal tracheostomy tubes. Every night she would cough for hours, cough up all the mucus when I would spend the night at my grandparents' house. I remember this like it was yesterday. And when I'm rounding in the ICU now, I see people get trachs, and they're complaining about coughing. I always tell them, my grandmother had one of these for 70 years that wasn't cared for by a physician. You're gonna be fine. She wore that from the age of 26 to 95 until she died, peacefully in her sleep. Imagine that, 26 years old. Not only a poor outcome, but one directly related to what we will see. Patients who have had horrible experiences with doctors. Some will be anxious, scared, dismissive, even combative, but we need to offer them an olive branch and try and connect. Because it isn't their fault what happened to them. And it's our job to communicate to them in a way that gives them a sense that we care, they matter, and that they have control of their decisions. Towards the end of my first year of fellowship, I was rounding on the pulmonary service with somebody you guys are gonna recognize here in a minute. He was one of my favorite attendings. I went to KU Med for a pulmonary critical care fellowship. And of course we had attendings that tried to make things really hard. Dr. Satterwhite. And this is SQS, Dr. Simpson. We went to the KU basketball games together. But he was one of those attendings that always said you could do anything. And he was very open, always wanting to discuss things. We were walking down the hallway, and I was with this liberal ponytailed man, and we were discussing a 70-year-old black female patient who was in the CV ICU. Apparently, she was being non-compliant. And due to her significant oxygenation issues, we were asked to see her. Normally, traditionally, you guys all know this, I would go first, I was the fellow, and I would go present to Steve. But Steve was kind of cool. He was like, hey, let's just go together and just knock this out. So we walk up to the room, we go through the doors in the CV ICU, and I can kind of see her being a little unreasonable and screaming, and I was like, Steve, like, relax, let me go talk to her. I walk in the room, and you judge kind of what's going on, and I was just like, Mom, let me tell you what's up. Let me tell you what's going on and why you're in the hospital. I don't think we've done a good job explaining, and I'm here to explain it. It's not always this easy, but in this case, it just was. I told her everything that was going on. I drew pictures on the whiteboard. I made sure she understood. She was calm and accepted what I told her. Steve and I walked away down the same hallway we were in on the way there. He turns to me and he says, how did you know to call her mama? You just know. And I just knew. But I also know that same trick wouldn't work on my mom or my very proper grandmother, and especially my aunt, who probably edited that line into my speech. We're not all the same, right? Black people aren't all the same. But I always knew I could communicate. And when I was challenged to think about how I arrived here, I looked within. I'm trying to teach individuals like my grandparents in times of need. I understand my purpose, and I'm not gonna allow life to make me forget why I do what I do. And I don't think you should either. I will always learn more, but the goal is to connect dots, not collect them. The relationships that I've developed with companies allow me to communicate or educate the masses, people like my grandparents in times of need. Being able to do that has led to stronger relationships with academic leaders across the country. This has led to multiple media opportunities, but my purpose remains the same, to educate. I feel there are two ways to become a leader amongst our wonderful field of pulmonary and critical care. You can publish papers or speak from a podium or media chair. I forced myself up to the podium by taking an unpaved path to become a leader. I'm going to continue to foster my relationships and teach others how to do what I did loosely and unintentionally, but now with intention. I will continue to lead and teach with a purpose, owning my time, knowledge, and the dedication I have put forth to carry out my goals and create my own personal vision of success. I hope you have, or you will find your own personalized life balance too. It has been well earned or is well overdue. Find your purpose, Communicate with not only your colleagues, but with your patients, their family, and their friends. Own your time and do all of this with a smile. Thank you for your time and your attention. I'm Jamie, a pulmonary critical care, internal medicine, physician, producer, educator, content creator, daddy, husband, son, and brother. Thanks for the gift of allowing me to communicate.
Please welcome back to the stage Doctors Doreen Adrizo-Harris and Anissa Das.
Wasn't he wonderful? Thank you,